We are going to transition rapidly into session one. And our goal for this session is to examine some of the data illustrating the technology-related pain points for frontline care providers that serve as potential opportunities for innovation. Our format for the next half hour will be 3 10-minute presentations that explore some creative solutions for prior authorization, in-basket management, credentialing, recertification, and other aspects of documentation burden. And here again, we're going to save the Q&A till after the following session, but please continue to put the questions in the chat. I'm going to briefly introduce our 3 speakers now so that we can then transition between the sessions. Dr. Lisa Rottenstein is primary care physician and assistant professor of medicine, as well as associate medical director of population health at Brigham and Women's Hospital. Vicki Tiasi is a nurse, assistant professor, professor of health informatics at Weill Cornell, and also director of research science at New York Presbyterian. And finally, Lisa Asunen is managing partner at Venture Valkyrie Consulting and has over 30 years experience in healthcare as an entrepreneurial operating executive, venture capitalist, and strategy consultant. So we will again jump right in, and Lisa, we'll let you take the floor.
Thank you so much. And I am going to start sharing my screen. Let's move this aside. All right. Thank you so much for having me here today. It is wonderful to be in this audience and really looking forward to the discussion. I'll be talking today about EHRs, the physician experience, and the road ahead, and I'll be talking both from a research perspective and then also from a perspective of implementation. So I will be talking today about why to focus on the electronic health record, the evidence we have to guide our innovation, and then some principles for identifying and testing solutions. So why focus on the electronic health record? We know that the electronic health record, since its widespread adoption with the HITECH Act, has had some positive effects on safety, on the way we share information. And yet, as was really well mentioned in the previous talk, it has also had some drawbacks. So this is a slide demonstrating the impact of the electronic health record on our time. This is data from across the United States, Epic installations across the United States, more than 350 installations, showing that physicians spend a significant portion of their time on the electronic health record. These are very conservative estimates because they only measure time actively interacting with the electronic health record, so clicking or typing, and they aren't able to take into account physicians who may work less than full time. And even with those caveats, we find that primary care clinicians are spending about 2 hours a day actively interacting with the EHR, and that there are significant differences across specialties, with primary care clinicians spending about twice as long as surgical specialists. And the other thing that I will highlight from this study is that a significant proportion of the time spent on the electronic health record is on documentation, on notes. The electronic health record has also allowed us to communicate with each other and with our patients, but again, with some unintended consequences. So from this same study, we showed that on average, primary care clinicians are responding to about 35 messages a day, with slightly less for medical and surgical specialists. Primary care clinicians receive 5 times as many patient messages, twice as many team messages, and 15 times as many prescription messages per day. And the thing I'll highlight in this slide is that a significant proportion of the messages we're sending are actually between ourselves, so to other team members, and then messages associated with the system itself, with a smaller proportion coming from our patients. We also know that there are significant gender differences in time on the electronic health record. This is a study from a large ambulatory network of clinicians who mostly practice full-time. And we found that women physicians were spending significantly more time, about 40 minutes more per day, even after adjusted for specialty and other factors. And the majority of that time was derived from documentation time from notes, and having an impact as well on work outside of work. And this is interesting because we know that there are sometimes better outcomes for women physicians, that there are different expectations of women physicians, and yet they are spending more time on the electronic health record. And in work we're doing now, we have actually found evidence from a national data set that among primary care clinicians, women physicians may actually be less likely to have documentation support, despite the fact that, as you see on this slide, they're spending more time on notes. Some additional evidence that our group is working on. We have a paper coming out in JAMA Network Open this month that really emphasizes the point that technology is more about, the experience of technology is more than about the technology. And it is heavily shaped by local context, which is something for us to take into account as we consider what might improve the physician experience. So we show that physicians and physician-owned practices are significantly more likely to be satisfied with the electronic health record than those in non-physician-owned practices. And that is even after taking into account the specific electronic health records they use and the support they might have for documentation. Again, emphasizing that culture and systems really also play into our experiences with technology. And given the amount of time we're spending on the electronic health record, we looked into whether there was an association with quality, and in work that is still underway, we actually found a minimal relationship between the time we are spending on the electronic health record and measures of ambulatory quality. So not very much. Why does this matter? We've touched upon this already, and this audience is familiar with these concepts, but just to emphasize them, that after hours time on the electronic health record has been shown to be associated with burnout. And burnout is associated with turnover, with cutting back on clinical time, and with worse clinical outcomes and safety. What evidence do we have to guide our innovation? I'll highlight two areas, one really focused on tools within the EHR and the other on supports outside of the EHR. So this is a study that we did based on national EPIC data from more than 240,000 physicians, and we wanted to understand how does the way that physicians document interact with the time that they spend on the electronic health record. And we were able to ultimately show that for the physicians who are mostly using manual entry, so just typing into the electronic health record or using copy paste, they were spending significantly more time on the electronic health record in total, on notes, and outside of scheduled hours on a per visit basis than those physicians who were using templated text in some format or who were using transcription and voice recognition. And it's a pretty significant gap between manual entry and transcription and voice recognition, and this is even accounting for the length of notes. The issue is, though, that we know that different technologies are used differently across specialties. So from the same study, we show that even though transcription may be associated with efficiency benefits, surgical specialists are much more likely to be using transcription. Primary care clinicians who are spending the most time on the EHR, much less likely to. And our medical specialty colleagues end up using more copy paste, which in addition to being associated with more EHR time, has been associated with note bloat and in some cases actually inaccurate documentation. And so this tells us that while some technologies may be associated with efficiencies, they may not in their current form be the right choice for all specialties. And that's an area for us to work towards. How do we take the technologies that we know have benefits and make them work for more clinicians? And we particularly should be thinking about the specialties whose value is really communicated through detailed reasoning and documentation. Now, in terms of supports outside of the EHR, I want to highlight some evidence about scribes, and particularly a study about virtual scribes that was recently published by a group from Yale and New England Journal Catalyst. And one of their key takeaways had to do with physician response, essentially, to scribes. So they found that when physicians responded to scribes or worked well with them, they saw significant benefits in terms of documentation time, documentation length, and quality. But scribes didn't work for all physicians. There was variability in virtual scribe proficiency, and for the physicians who didn't respond, so to speak, there really weren't benefits. And that's something, again, for us to keep in mind, that there is not going to be a one-size-fits-all solution for our clinicians. And now just some principles on identifying and testing solutions, again, both from a research and an operations standpoint. We really should be focusing on making our technologies and solutions easy to use. So for example, transcription and voice recognition, as I showed before, has time benefits, but there is a learning curve that's been shown in the literature. And so to the extent that we can reduce the learning curve associated with our technologies, our clinicians can reap their benefits. Our technologies need to fit within existing workflows, and we shouldn't be in a situation where we are creating the workflows around the technologies, or at least should avoid that, and then should bear in mind the differing workflows across different specialties, especially given the different time burdens of the EHR in different specialties. Our solutions need to be sustainable, and I will also highlight a piece of equity around this. There are some institutions, to bear the cost of technologies like scribes, ask physicians to see extra patients to make up for those costs. And it's interesting to think about that in the context of our women physicians who we know are often spending more time with patients, spending more time on the EHR, and what does that mean for their ability to have documentation support. And lastly, we should be thinking about quality and satisfaction with these technologies, and ideally, they would even be enhancing our documentation while enhancing our satisfaction. So some key principles. We really should be involving our end users in design of them. And when I say end users, I'll just emphasize that, yes, that is the clinicians and the physicians, but it also should be our administrators who are creating the workflows around our technologies. And then also our patients who increasingly have access to open notes and are engaging with their documentation. We should really be thinking carefully about how these technologies fit into our workflows, minimizing the learning curve, and then gathering feedback from users after implementation. And again, thinking about who the end users are in a broad sense and gathering that feedback broadly. What is promising? First of all, I'd like to highlight technology that enhances teams. We know that teams improve outcomes. And so to the extent that we can leverage what we've learned from other sectors about how we can best collaborate around our patients' care, it will be a benefit to our whole healthcare system. Virtual scribing has promised as a way to build upon the positive effects of scribes in a scalable way. AI-powered messaging tools can help us interact with our patients and get them the information they deserve while addressing the increasing prevalence of messaging that we've seen, particularly with the coronavirus pandemic. And then lastly, as was highlighted in the last talk, ambient documentation tools really have the potential to get us back to really focusing on our patients in our encounters. And ideally, those would be in a way where the documentation was as of high quality as it would be when we were primarily spending the time on the documentation. Thank you so much, and I look forward to engaging with this audience.
Thank you, Lisa. Really fantastic. And even in addition to the technology, I think you really highlight some important gender inequities that we've largely been blind to over the last 2 decades. That is a critical dimension to this. So thank you for that wonderful talk. Dr. Chiasi will transition to your session. And again, please drop questions in the chat. After the following session 2, we'll have some time for interaction and Q&A.
Perfect. Thanks so much. And thank you for having me here today. And thanks to the Academy for elevating this important topic. So to set the stage from my perspective, I really believe this is about managing technology and practice polarities. So we really neglected the practice piece for far too long. So actually, if you could please advance the slides a bit to fill out the slide, I would appreciate it. Thank you. Awesome. Thanks so much. So, so with this imbalance, if you will, we've had this state of moral distress with learning new technologies, taking time away from patients, and the fear of medical errors. And this is really a result of over-focusing on the technology tools and platforms. But I think the good news is that we can do both. So we have innovative solutions. You've heard some of those already today. We have patient-generated health data. We have other external data sources that can really help us with efficiencies. But this requires a real focus on the evidence-based delivery of health IT tools to each clinician discipline scope of practice. So next slide, please. I won't belabor this. We've heard a lot of it already, and I think the audience is familiar with the pain points. However, I think the interesting aspects about this and these items here is that I could have easily used this slide 10 years ago, maybe more. So we've been struggling this for quite some time by really thinking about how can we use the evidence that we have generated so far and really make some measurable strides. So next slide, please. So in thinking about how we use the existing evidence and also create more to move this work forward, past simply pointing out what's wrong and really getting to action items, I think one bright spot is earlier in 2021, there was a symposium sponsored by the American Medical Informatics Association, NLM, Columbia University, and Vanderbilt University, looking at documentation burden and the specific goal of decreasing documentation burden to 25% by 2025. So over a series of weeks, groups convened to hear the current evidence and really start to carve this path forward. This resulted in the 6 domains you see here. And now with some multi-sector support, there will be various work streams to create action plans in these areas. However, I won't have time to cover all of these topics today. So instead, I'll briefly review evidence in a few key areas. So first is usability. Next slide, please. So interestingly enough, there actually are ONC, the Office of the National Coordinator for Health IT, have requirements in place to promote usability. So EHR vendors are required to use that user-centered design approach, emphasizing their role in design and development. As Lisa just mentioned, they must conduct usability testing of certain EHR features. However, we still have some problems. And so, first of all, maybe not all of the vendors have adhered to the requirements, and somehow those products have been certified. But however, secondly, and more importantly, there are several other factors that have an impact. And the biggest one is the customization and configuration choices made by both the EHR vendor and the healthcare organization during implementation. So this has led to variability from EHR to EHR. And the old adage, if you've seen one EHR, you've seen one EHR. However, the extent of the variability was, and I would say to still extent, is largely unknown. So I think understanding this variability is important to moving some of our tools forward and thinking about how we work on policies for the design and development moving forward. So here I'd like to point to a study by Ratwani and colleagues with really rich results. They looked at 2 EHR vendors and physicians, about 15 physicians from 4 different health systems. So this study revealed a wide variability in the task duration, clicks, accuracy. For certain tasks, there was an 8-fold difference in time and clicks from one site to another. And they also found issues related to whether or not copy-paste was common practice. They found silification of notes, meaning there could be double documentation across disciplines, or the inability to see certain items documented by other disciplines. The kitchen sink approach, which is the idea of huge notes that have difficulties in supporting information needs and finding information, and then lastly, the readability of the output. So all of these can certainly be managed with proper usability testing. Next slide, please. So the next area here is looking at some of the workflow challenges. So as a nurse informatician, this is near and dear to my heart. So there are a few excellent studies in this area by Kim Unertl and her team looking at the value of evaluating the impact of health IT on workflows. So one was a systematic review that looked at the methods used to study workflow and health technology and found the importance of contextual factors. So thanks, Lisa, for setting that up. So again, really this idea of the modular approach, implementing, first the OR module, first the cardiac module, or one provider discipline and then another, that is problematic, but we still see it happening today. So this work developed a set of 10 guidelines on focusing the workflow and information flow interconnections. So making sure that is tightly coupled as part of the design and development. And then another great study in the area of workflow is by Brian Art and team. They did a thorough workload assessment of primary care providers and the EHR. So they found a number of items that you see here. So the interruptions and disruptions due to technology supported guidelines that have placed hard stops within clinical workflows. They've also found the inappropriate allocation of EHR tasks to clinicians. So again, this really requires involving the clinicians in the early stages, mapping out those workflows and ensuring they're incorporated into the design. And then lastly, which I think is an interesting one, is the concerns about the amount of time required to become proficient in EHR use. So I think that directly speaks to the intuitive nature of the products and how they are matching workflows. Next slide, please. Last big area here is looking at some of the implementation and adoption considerations. So, implementation is very confounded by human factors, and they are frequently overlooked, in my opinion. So I think if users believe that the technology is easy to use and beneficial and supplying them the information that they need and supporting their decision-making, then adoption has a higher likelihood of success. However, the converse, if there isn't a relative benefit to having that new system to what has been available to them in the past, it's reasonable to assume that the adoption will be resisted or be very problematic. So I'll draw you to a study here by Susan McBride and her team. They surveyed thousands of nurses across the state of Texas looking at variables related to satisfaction with EHR implementation efforts. And I think a lot of really interesting findings out of this study. So really thinking about the need for efficient clinical decision support. I would say that's not always front and center. It's a lot around data input, but not always thinking about how we're supporting the clinical decisions of the nurses. Problems with multiple or numerous interaction alerts. Full end-to-end electronic medication reconciliation. That is important because if that's going to hinder and again be worse than what they had before, then there'll be difficulties with satisfaction there. Issues related to core system performance and its impact on the nurse-patient relationship. So all important factors to consider on the human side of the implementation. Next slide, please. And because I think it's so important, it needs its own slide. Just one final topic here that's sometimes missed in discussions is around alarm fatigue. So, as you can see here, this study is from 2016. This is the last comprehensive study on clinical alarms. So in this study, they found an average of 350 clinical alarms per patient per day in an ICU. So not inconsequential. So certainly here, this is important to consider. In fact, as part of the recent Future of Nursing report, our committee really highlighted this as a major stressor for nurses and its contribution to nurses' well-being. And certainly referenced the systems approach that was noted in NAM's 2019 report. I think this is an area that we need to continue to study and produce further evidence on. Next slide, please. We've heard most of these already, so I won't go into the specifics on potential interventions, but I think, what I'd like to highlight here is that if we make the same mistakes that we have made with EHR implementations, we're going to have real trouble moving these interventions forward. So I hope that we can really look at the evidence and see where we have the opportunity to improve. So I think by using other forms of data capture devices, interoperability, I can certainly envision a time where a nurse no longer has to perform that head-to-toe assessment when the patient walks in the door, but instead, look at the patient, look at the data that are automatically populated, contextualized, and visualized in a way that supports efficient critical thinking, using critical judgment, and really safe and accurate decision-making for the best care for the patients. Next slide, please. So I certainly recognize that this is hard. I think it, as we've already heard here, it really means restructuring priorities in our clinical healthcare system. I love thinking about the clinical models that need to be redesigned, partnering with industry, and really continuing and advocating for policies that reduce these technological stressors and then measurably improve our clinician well-being. So thanks so much for your time today.
Thanks, Dr. Tiasi. Some really great insights, and thank you for spotlighting the human factors element. And I think also really important of learning the lessons from the past of technology implementations as we think about these exciting new opportunities we're considering today. So with that, let's transition to Lisa Sunan for our final talk in this session.
Great. Hi, everybody. Let's get the slides up here. Just a heads up, I'm having a little bit of Wi-Fi challenge today, of course. So hopefully this will be okay. And what I really wanted to talk about wasn't the problem, but was what's standing in the way of solutions. I come at this from a very different place. I'm a venture capitalist and an entrepreneur, not somebody who lives in the health system every day. And thank God for that. I have to say, the tools I get to use are pretty easy. And as a venture capitalist in the health tech ecosystem, my job, among other things, is to find new innovations, fund them, and take, some financial risk on their existence, making sure they can come to market, for instance, allowing helping those companies to scale with more capital, and helping the companies that we invest in connect to customers like the health systems, which is particularly true when the investors themselves are health systems, which is often the case these days. We have many, many venture capital funds that are funded by health systems or that are, have contributions from health systems into their limited partner capital base. So, thinking about the issues raised by National Academy of Medicine, some of the issues anyway, about these challenges of these technologies and the barriers to them being adopted, I wanted to say that, as others have said, and I won't belabor, there's a lot of stuff available now to solve the problem. There's all of the companies and technologies that the previous speakers mentioned. You look at the stuff that David showed, it's really incredible, what it can do. And I'll show you a few others very quickly, because that's not what I want to dwell on, but Orbita is another one. It's a conversational AI, so voice and chatbot, able to automate many interactions. And they've used this to good effect at Medstar, which may or may not be in the audience today, around the COVID pandemic, saving significant staff time. Falls under to the EMR in this case, that allows some of that data to get automatically updated. So there's some great service provided by this technology, very much in market. Wellsheet, you're going to hear more about, I think, later today, directly taking on the source of stress of the interface to the EMR. They have an integration with Epic and Cerner and Athena, and deploy quickly, and in theory anyway. Not in theory that they can't, but in theory that there's other challenges, and really improves the patient throughput and reduces clinician burnout from the experience of using the EMR. So you can see some results here from RWJ Barnabas, which has implemented the system. They have quick training, rolled out quickly, resulted in dramatic reductions in EMR time for the clinicians, and faster patient throughput, which is, I'll foreshadow a comment later. That's something that's very much looked at, and generally gives great patient satisfaction, much in excess of what is there today with using the EMR. Lastly, one called Wonder Medical. This is a new company that's coming slowly to market. It's basically like a healthcare focused mashup of Slack for online collaboration, cloud collaboration, and a thing like a Facebook for community activity, but all HIPAA compliant. Can have send video, send imaging, send commentary back and forth, and use cases for consults on the fly. You can stream imaging information, for instance, from one doctor at one hospital to a person they may know in another country altogether to get a consult or some feedback, or somebody in their health system, or use it among staff, especially among temporary staff, to get them in and out of the system quickly without having to go through a lot of trouble. There's many different use cases for this technology that are currently being evolved. But I'm going to come back to the VC thing. When we think about what to invest in, there has to be a big problem to solve. Check, we've got that here. It's not a short-term problem. Check, we've definitely got that here. It's large and growing. We have that. And the companies are available that can solve the problems. So those are great. We check those boxes in solving the physician and clinician burnout problem. But low barriers to entry and allowing the companies to grow revenue rapidly, that's a real challenge. And it's not a company challenge, it's a customer challenge. What companies find, young companies especially, when they go to sell to health systems to solve problems, is that they just cannot do it. They cannot get in. They can't. It takes 18 to 24 months to sell something if they ever can. There's a million reasons why they are unsuccessful in getting things acquired, technologies acquired, starting with it doesn't integrate with Epic very easily or at all. And and the third reason I would say, and one that I think is often not discussed out loud because it's considered rude, but here I'll go, is if the technology doesn't immediately drive new revenue, nobody wants to spend money on it. So what can health systems do differently, perhaps? And I'm going to talk about different audiences, not just blame it all on health systems, because it's everybody's problem and everybody can do stuff to participate in fixing it. But I don't think there's a healthcare company alive that sells tech to hospitals who haven't heard, this last quote at the bottom, which is no one gets fired for waiting to Epic to solve this problem. And if that's what we're going to all do, we can convene this meeting in 200 years and give the same slides, because it may not ever happen. So I think health systems have to step up to the plate here to do more than just think about tech that increases revenue. They have to invest in their people and invest in their infrastructure, much of which is quite old, and choose to solve the problem by buying what works, not just what's coming from core vendors. Best of breed is not a bad word or bad phrase. Give clinicians themselves time, space, and funding to collaborate with the vendors. This is another problem. Oftentimes the health systems have an innovation group sort of in a corner somewhere, but getting into the operation is almost impossible. So the pilot goes fine, but the spread scale never happens. So working with vendors as a beta site where you're collaborating and with the goal and in the commitment to expand is great. And I think that should be done more often, as I think Barnabas has done with Wellsheet, for instance. If you have a venture fund at your health system, make your operations people collaborate with the companies that they pick. Put them together to work together to select companies and implement the product. You get a double win. You get a return on your investment and you get a return on your investment. So it's worth doing. Venture capitalists, we've gotten very nervous about investing in technologies, new solutions to these problems. It's one thing for Microsoft to do it. It's another thing for a venture fund to do it, where they have to make a return on our investment in a shorter period of time. So we need to start, working with health systems to better understand what they will buy and demand that companies that we would invest in show better evidence of clinician frontline user engagement in the product process. I think that's a big gap that the young companies forget all the time. We need to commit to this sector. Many have run from it. Entrepreneurs, in response to that, can really be much more diligent about understanding the problem. We've got some examples of those who've been great about it, but not everybody has. And a lot of these products can be difficult to use and aren't empathetic to the users in the manner in which they need to be. And they aren't as easy as some of the ones I showed you today to implement and operate. So it, makes more trouble than less trouble before you can get any solution. And we can also ask our entrepreneurs to do more about testing and refining with customers early on, as long as the customers are willing to do so in a reasonable way. And that's been a big, big problem. And I think the government has a role here too. And I, wonder if there isn't a place like the High Tech Act, similar kind of model to solve the problem. We should think about it in perhaps a more constructive and bigger way. Enforce the interoperability and data sharing rules in a much more proactive way, similar to some of the other requirements we talked about for certification. Perhaps often up its own sites, its own clinical sites like the VA or others, and adopt some entrepreneurs and residents to help bring proof of concept for some of these technologies so it's more easily spread. And then consider things like standardizing, and centralizing credentialing or other things that take some of the burden off of the health systems to make it easier for them to do other things that are of higher value. So those are my thoughts today. I really appreciate being included as sort of a off the beaten path speaker. Thank you very much for the time and for the interest.
Great. Thank you so much, Lisa. That was extraordinary. Really so pleased to have you join us today and really bring a fresh and different perspective and a set of eyes to this. And I know you don't leave anything on the table. So with that, thank you so much.